This lecture wraps up Learning Unit 8. We'll touch on the urinary system in some parts, but we're focusing mostly on homeostasis, thinking about fluid balance, electrolyte balance, and acid-base balance. In terms of the learning goals, I want you to be able to identify outward and inward pressures and the relationships between them that allow fluid to move between compartments. We'll look at edema as a case study and kind of see how problems with outward and inward pressure balance might contribute to edema. We also want to keep thinking about the renin-angiotensin-aldosterone system, or RAS, specifically ADH, which is also called vasopressin. That's what your reflection is on this week or this past week, and it's kind of an ongoing case study that we have. So that one will be very important, as well as aldosterone. So we'll revisit those hormones. We'll think about specific cell types within the collecting duct system of the kidneys. So thinking about principal and intercalated cell function, knowing the main functions of electrolytes broadly. So here we're going to talk about the main electrolytes. Your textbook and other textbooks kind of talk about the general functions of each individual electrolyte. I just want to focus more broadly on why we care about electrolytes. In specific chapters, we've talked about, for example, the role of sodium and potassium in depolarization and repolarization. We'll revisit that again, but for the upcoming lecture exam, I'm not going to test you about each main electrolyte individually. I do want you to kind of be familiar about what causes deficiencies and excess in these electrolytes, and also you should know how vitamin D relates to calcium absorption. We're also going to be thinking about different buffering systems within the body and comparing renal or metabolic and respiratory compensatory mechanisms to deal with kind of changes in acid-base balance. I want you to know the pH ranges of acidosis and alkalosis, and then for each of the 4 acid-base imbalances, so respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis, you should be able to identify its cause as either an elevated or deficient carbon dioxide or bicarbonate. And we'll get back to that at the end of the lecture. So at the end of the lecture, I'll clarify kind of the type of question you might expect to see from those different problems. Okay, so again, we're continuing chapter 26, thinking about fluid, electrolyte, and acid-base balance, and tying together a lot of ideas about homeostasis. So we're going to cover all of the different sections, body fluids and fluid compartments. We'll do a review of water balance, which we covered a little bit more in the last lecture, electrolyte balance, acid-base balance, and disorders of acid-base balance, specifically respiratory and metabolic acidosis and alkalosis. So this is kind of a continuation of themes from Bio 5 and anatomy. This is something that you're already kind of intuitively familiar with, but we have this idea that fluid is found in different sides of the semi-permeable membrane of the cell. So when it's intracellular fluid, that means that it's inside of the cell. Anything outside of the cell consists of extracellular fluid. So that extracellular fluid can mean interstitial fluid, also called IF. That's all the fluid that's just kind of floating around in between our cells. The plasma fluid is that fluidic grounding matrix of the connective tissue that makes up our blood. So remember, cells are dispersed within that plasma. The plasma itself is part of extracellular fluid because it's just kind of floating around. It's not contained within semipermeable membranes of cells. So these distinctions represent fluid compartments. They can be fluid inside of intracellular context or extracellular. And extracellular mostly consists of interstitial fluid, or IF, and plasma. So when we're thinking about the movement of fluids, a lot of the fluid that we're talking about is water, and different substances are dissolved within that water. So electrolytes are ions, and more specifically, they're minerals that have been dissociated from salts and carry an electrical charge, so ions. Examples of these that are really common in the human body include chloride, sodium, calcium, and potassium. And so remember that the concentration of electrolytes has an influence on the movement of water because water moves along its own concentration gradient. So it moves from where there's a lot of water to where there's relatively less water. In other words, it moves from where there's less solutes to where there's more solutes, or from where there's less electrolytes to where there's more electrolytes, because water likes to dilute things. So that passive movement of water that does not require any energy along its own concentration gradient is called osmosis. And remember, this is due to just random molecular motion. It doesn't require any energy. It's just kind of net effect. So when we're thinking about the electrolytes that are found throughout different fluid compartments, they tend to be fundamentally different between the ICF, or the intracellular fluid, and the ECF, or the extracellular fluid. And remember, this is the ICF. The ECF consists of the plasma and the interstitial fluid. And it turns out that the two different types of ECF, the plasma and the interstitial fluid, are more similar to one another than either are to the intracellular fluid. And if we look at a plot describing the concentrations of different electrolytes in these different locations, we see that trend. So in yellow, we have the intracellular fluid. In blue and red, we have the extracellular fluid. And we see that for sodium, chloride, bicarbonate, potassium, phosphate, calcium, and magnesium, there are similar patterns between ICF and ECF. And in general, the intracellular fluid is very high in potassium and phosphate, and the extracellular fluid is very high in sodium and chloride. Remember that a high concentration of potassium inside the cell and a high concentration of sodium outside the cell is key for maintaining resting membrane potential and allowing depolarization in neurons, in muscle tissue, different things like that. The one difference here between that pattern, the one area where interstitial fluid and plasma really differ is their relative concentration of protein. So the interstitial fluid is pretty low in protein, but plasma is much higher in protein. Remember, there's immunoglobulins and hemoglobin floating around, and then the intracellular fluid is quite high in protein relative to either one of those. So when we're thinking about what other forces cause the movement of fluid, it's really important to consider outward forces versus inward forces, specifically when we're thinking about movement between fluid compartments and between plasma inside of the capillaries and interstitial fluid and other types of fluid compartments. So we talked about this in the last lecture, but I just wanted to revisit when we're thinking about outward forces, so moving out of the capillaries, like moving out of the glomerulus, this is hydrostatic pressure or capillary hydrostatic pressure. There's a force that's exerted by that fluid against the walls of the vessel, so it's the pushing outward, it's an outward force, an outward pressure. Blood colloid osmotic pressure, on the other hand, is an inward pressure. It draws fluid inward, and it's affected by proteins and other solutes inside of the fluid. So a huge example of this is albumin, which is a very important plasma protein. So again, this is drawing fluid inward. So when we compare these values, the capillary hydrostatic pressure, or CHP, and the blood colloid osmotic pressure, or BCOP, when CHP is higher than BCOP, there is a net outward pressure, and we have what's called filtration or fluid leakage. So fluid is leaving that vessel. When they're equal to one another, we have no net movement. So the movement outward and inward equal each other and cancel each other out. And then when the CHP, the capillary hydrostatic pressure, is less than the blood colloid osmotic pressure, then we have a net inward movement, a net inward pressure, and we have reabsorption. So it's the movement of fluid back into these vessels. And remember, we talked about this when we were talking about glomerular filtration rate and net filtration pressure. So we have the outward pressure from the glomerulus, and then we also have blood colloid osmotic pressure as well as capsular hydrostatic pressure. So in this case, that capsular hydrostatic pressure, which is different from capillary hydrostatic pressure, is an inward force because it's hydrostatic pressure of the capsule, which is opposite from the glomerulus. The glomerular blood hydrostatic pressure that's another way of saying capillary hydrostatic pressure because the glomerulus is a capillary network. So we saw kind of a more complex example of these different values when we were looking at glomerular filtration rate. In general, when that hydrostatic pressure outweighs the osmotic pressure, we have filtration moving outward. When the hydrostatic pressure is less than the osmotic pressure, we have reabsorption. So one example of this happens in edema, and remember filtration occurs, movement outward occurs when CHP is higher than BCOP, but one mechanism of edema is when you have high fluid leakage for one of two reasons, or maybe a combination of both. So remember, filtration leakage happens when CHP is higher than BCOP, and so if you have a situation where you have very high hydrostatic pressure, that's going to make it higher than BCOP. You have fluid leakage, movement out. If you have very low osmotic pressure, then it's going to make that lower than CHP, and so you have fluid leakage, you have movement out. So both of those situations might result in edema, and that's commonly associated with pregnancy, allergies, localized injury, and medication. Especially, I'm sure a lot of you are familiar with edema during pregnancy. You see this pitting that occurs. You can kind of press on feet, like different extremities, including hands, and see a little bit of this pitting where the shape remains. And so another example of edema happens when you sit or stand for long periods of time, if you have heart failure and pulmonary edema, damage to different vessels, liver cirrhosis, kidney damage and disease, and these can kind of amplify one another. So a lot of the time with pregnant people, we encourage them, if they've been sitting for a long time, to stand up and move around to prevent edema. If they've been standing for too long, sit down and elevate your feet to prevent edema. And elevating your feet and your extremities are very helpful for this process in general. Okay, so just a brief review of fluid balance. We talked about the definition of osmolality, how we calculate it in plasma as solutes in blood plasma over water in blood plasma, and our bodies respond to changes in osmolality and osmolarity by releasing different hormones and regulating those fluid levels. There's a few different sources of fluid into our body and output, and so it's important for those to balance one another to maintain fluid within our body. So we get fluid through a couple primary sources, either through pre-formed water, which means the water has already been formed. We ingest liquids, and we have food that has water in it, or we produce water in our body through dehydration synthesis. So remember, that's very important for anabolic reactions through the formation of larger molecules. And then there's a lot of sources of fluids leaving our body, including the kidneys and the urinary system, our skin, so evaporative cooling and sweating, our lungs, as well as our GI tract. So those different sources of intake and output need to balance one another out in order for us to maintain fluid levels in our body. So if we don't have enough water in our body, that sends thirst signals, and it does that in a couple different ways. So remember, having insufficient water in our body causes a decrease in blood volume, which decreases blood pressure. That decrease in blood pressure initiates the RES, so the renin-angiotensin-aldosterone system, and so that indirectly increases angiotensin II, which is the converted activated form using ACE enzyme. Insufficient water in the body also increases blood osmolality, so you have more solutes relative to your solvent. That activates osmoreceptors in the hypothalamus of the brain and also causes dry mouth. And so all of these serve to stimulate the thirst center in the hypothalamus. That increases thirst, you drink more water, and then your blood osmolality is decreased and all the signals balance out. So it's a negative feedback loop. So ADH specifically is a very important part of this process. Antidiuretic hormone is responsible for constricting arterioles, so you have less blood going to be filtered. And then you also have increased reabsorption of water in the kidneys due to the insertion of aquaporins into what are called, or through binding to receptors on principal cells, which we'll get back to in just a moment. So remember, a diuretic is something that increases the volume of urine. These can be different types of medications, as well as things like caffeine and alcohol. Antidiuretic hormone is something that is a chemical signaling molecule that does not act as a diuretic. In fact, it's the opposite of a diuretic. So it decreases the volume of urine rather than increasing it through chemical signals. So again, more succinctly, ADH is a hormone that controls the amount of water reabsorbed through the collecting ducts and tubules of the kidney. And here's its chemical structure pictured. So the way that does this is by stimulating insertion of aquaporins into epithelial membranes. ADH binds to principal cells, it sends the signal, and so these, we can see over here that there's vesicles within the collecting tube cells. These have aquaporins stored in them. So these little pink circles are the aquaporins. And when ADH binds and sends the signal, the aquaporins are inserted into the plasma membrane of these cells. And so when water comes through, so water is coming down the collecting tube, if you have more openings, then you have more likelihood of water passing through. It's leakier, so you have more water getting reabsorbed into your plasma. If you have less of those, water passes straight through, and so you have an increased urine volume. So when ADH is working, you have increased water permeability, increased reabsorption of water, and decreased volume of urine. So you have low volume, high concentration urine, and that all works to then decrease blood osmolality. So there's a lot of different hormones that act on different regions of the nephron. We've talked a lot about angiotensin II, ADH, and aldosterone. We'll get back to some of those in just a moment. Also parathyroid hormone we talked about when we talked about endocrinology. So that increases levels of calcium in the blood and in part acts on the nephron. There's also atrial natriuretic peptide, and so that increases glomerular filtration rate and sodium filtration. Remember that the renin-angiotensin-aldosterone system is associated with the goal of increasing blood pressure. So it gets activated when you have low blood pressure. So for example, angiotensin II is synthesized in response to low blood pressure. Aldosterone is secreted in response to low blood volume, which is associated with low blood pressure. And ADH is secreted in response to high plasma osmolarity and low blood volume, so low blood pressure. So all of these are activated when you have low blood pressure, and they work to balance osmolality, and blood pressure. And remember here, you can see ADH binds to receptors on principal cells. So I wanted to expand on that in just a moment. But just a reminder about rest. So aldosterone regulates potassium and sodium levels. So when blood potassium is too high, aldosterone is released from the adrenal cortex. It targets the kidneys, and then the release of potassium decreases and levels normalize. Conversely, when blood sodium is too low, or not conversely, but also when blood sodium is too low, this same kind of mechanism happens. Sodium is reabsorbed more by the kidneys, and this normalizes levels. So aldosterone is really important for potassium and sodium level regulation. It increases excretion of potassium, it gets rid of it, and it increases reabsorption of sodium, it keeps it. So it's activated when potassium is too high or when sodium is too low. And that stimulation of sodium reabsorption then subsequently leads to increased water reabsorption. So when you have more sodium being reabsorbed, you are also reabsorbing more water and hanging on to it. So again, that serves to increase blood pressure, balancing out blood pressure. Aldosterone is activated in these situations, and then also when you have low blood pressure. Okay, so remember there's a couple different cells in the collecting ducts. There's principal cells and intercalated cells. And I know we didn't talk about this a lot in the anatomy review, but I just wanted to kind of emphasize it in this lecture. So when we're thinking about those two different types of cells, the principal cells are responsible for sodium reabsorption and potassium excretion, so the functioning of aldosterone. They're also important for binding to ADH and insertion of aquaporins into the membrane. So they are really important for RAS. The intercalated cells are involved in secretion and reabsorption of protons, bicarbonate, so they're managing acid-base balance. So principal cells are more about electrolyte balance and fluid balance. Intercalated cells are more about acid-base balance. So we're going to focus first on that idea of electrolyte balance and talk broadly about electrolytes that can get into kind of either excesses or deficiencies in those different types of electrolytes. So in general, electrolytes are very important for regulating osmosis. Remember, when we have a lot of electrolytes, that draws water towards them. They help maintain acid-base balance, especially bicarbonate. They're important for carrying electrical currents, so think about the functions of sodium, potassium, and calcium. And they also control the secretion of hormones and neurotransmitters. So especially calcium in terms of neurotransmitters. Another thing that electrolytes do is they can serve as cofactors. So proteins aren't, and especially enzymes, aren't always active. Sometimes they need to have a cofactor that binds to them and makes them into the correct shape. And so you need these cofactors for enzymatic reactions to occur and before binding can occur. So remember, you saw this plot earlier in the lecture. The main electrolytes of the human body are sodium, Na+, chloride, Cl-, potassium, K+, phosphate, HPO42-, calcium, Ca2+, and magnesium, Mg2+. Bicarbonate is also an important electrolyte, HCO3-, but we're going to talk about that more in terms of acid-base balance. So I'm going to walk you through each type of electrolyte or main electrolyte, and we'll talk about abnormal concentrations of them. So starting with hypo or low levels, and then hyper or high levels. So hyponatremia is the term for decreased or abnormally low sodium. The recommended daily intake or the necessary daily intake of sodium is 1 to 2 millimoles. As Americans, we usually have several hundred times that much per day, but we often, don't necessarily encounter decreased consumption as a cause of hyponatremia, though it does happen. Sometimes people, maybe with different medical conditions, or people are very concerned about having too much sodium and they cut it out completely. That's not good either. So you do need some. We just tend to get plenty. Another cause of hyponatremia, though, is increased water consumption or water intoxication without proper urination to balance out those levels. So hyponatremia can be caused like when you're running marathons and you're drinking too much water. It's really important to have hydration gels or Gatorade. If you're doing a lot of intense working out, you need to balance those electrolyte levels, the sodium levels. You might have heard of the story of Jennifer Strange, or We for a We. There was a radio station near Sacramento that had this challenge where whoever could drink the most water without using the bathroom, without weeing, could win a Wii, the console. And this woman, Jennifer Strange, won the contest, but then died really shortly after it, after complaining of a huge headache. And so what had happened here was she developed water intoxication and hyponatremia. Her sodium levels in her fluids were too low. And so in comparison to that blood osmolality, the sodium levels in her body cells were much higher. So that draws water in from the plasma, and in a lot of your body, that's not too big of a deal, but it can lead to bursting of red blood cells, and in your brain, which is surrounded by your cranium, by your skull, if there's any swelling, that can be really dangerous. And so she had swelling of the brain. She had this increased fluid in her first in her blood plasma, and then in her intracellular fluid, and then that was what ultimately caused her death. Hypernatremia is due to generally water loss, so the opposite of water intoxication or hormonal imbalances. And so there's kind of a diagram here for causes and diagnosis of hypernatremia. So the recommended daily intake of chloride is 750 to 900 milligrams. If you have very low levels of chloride, hypochloremia, that might be due to defective renal reabsorption. So you're passing out too much chloride in the urine, you're excreting it and not reabsorbing it, or excessive vomiting, diarrhea, or metabolic acidosis. Those can all cause hypochloremia. Hyperchloremia, so too much chloride, can be due to dehydration, so relatively you have less water, more chloride. Excessive dietary intake of sodium chloride or table salt. Some medications can cause it, as well as heart failure or cystic fibrosis. So in cystic fibrosis, you have a lot of very serious results. This is a genetic condition that causes a lot of really thick, solid mucus in the lungs. That is associated with a lot of bacterial infections, and there's some bacteria that are very diverse and can actually use the mucus as a substrate for growth. But it's associated with a lot of infections, and also there's a really high kind of increased production of sweat and salt within the sweat when you have cystic fibrosis. So it's also associated with hyperchloremia. The recommended daily intake of potassium is 4,700 milligrams. When your potassium levels are too low, that's hypokalemia, so you should know that term. We can say that it's absolute or relative. So when it's absolute, that means that you don't have it in your body. It's either not there to begin with, or it's been removed through decreased intake. So if you're not getting enough potassium in your diet, vomiting, diarrhea, or alkalosis can all cause absolute hypokalemia. Relative hypokalemia is usually due to redistribution. So if certain types of medication, or if you're having to use potassium to transport glucose, then you don't have access to it, and so that's considered relative hypokalemia. Hyperkalemia is generally due to diet, so excess potassium in the diet. So remember, when we have our resting membrane potential, so let's say that this is a neuron, and we have the axon. So in here we have a lot of K+, so a lot of potassium, and outside we have a lot of Na+, a lot of sodium. Remember that the movement of sodium into the cell is associated with depolarization. And then the movement of potassium out of the cell is more associated with repolarization and then hyperpolarization. And so if you have too much potassium, then you are not able to go through this part, the depolarization, as well. So if you have hyperkalemia, that causes severe problems with depolarization. Remember that depolarization is very important for skeletal muscle, cardiac muscle, and neurons. So hyperkalemia is very detrimental to those systems. Your recommended daily intake of phosphate ranges anywhere from 460 to 1250 milligrams. Hypophosphatemia is associated with overuse of antacids, alcohol withdrawal, and malnourishment or starvation. Hyperphosphatemia is associated with decreased renal function, acute lymphocytic leukemia, so different types of cancers. Phosphate's also found in the phospholipid membrane as well as inside of the cell. And so if you have a lot of cells actively being lysed or undergoing apoptosis or programmed cell death, then you have a lot of phosphate being released and you have hyperphosphatemia. The recommended daily intake of calcium is 1,000 to 2,500 milligrams. Low levels of calcium or hypocalcemia are associated with hypoparathyroidism. So let's break that down just a moment. Remember that the parathyroid secretes parathyroid hormone in response to low calcium levels. And so it's responsible for then increasing calcium and maintaining its level in the blood. If you have hypoparathyroidism, your parathyroid is not working, you're not secreting parathyroid hormone in response to low blood calcium, and so you're not able to respond to those low levels and you have hypocalcemia. Remember that parathyroid hormone affects the skeletal, renal, and digestive system, so this is kind of a widespread integrative problem. Decreased absorption of calcium may also be due to vitamin D deficiencies because activated vitamin D is really important for absorbing calcium. Hypercalcemia is associated with hyperparathyroidism. So if you have too much calcium, your parathyroid is working too much and secreting too much parathyroid hormone and kind of going above the set point or the range of calcium. It can also be associated with other types of malignancies. So we just talked about phosphate and calcium, and those are regulated in similar processes. So parathyroid hormone, which we talked about, dihydroxyvitamin D or calcitriol, which is the active form of vitamin D, and calcitonin, which is released by the thyroid in response to high calcium to kind of lower it back down, are all important for regulating both calcium and phosphate, which we see in this image on the right. So calcium and phosphate are both released from bone, excretion is modulated in the kidneys, absorption of calcium occurs in the small intestine, so lots of different factors being regulated with similar hormones and similar organs here. Again, dihydroxyvitamin D is the active form of vitamin D, and so you have to have that active vitamin D in order to absorb calcium within the cells of the intestinal villi. So you should understand that connection. That's also why in a lot of calcium supplements, they also have vitamin D. And finally, the last electrolyte we'll talk about is magnesium. You should have about 310 to 420 milligrams of magnesium per day, depending on your own physiological demands. So for example, pregnant people need to take a lot of magnesium and breastfeeding people as well. Hypomagnesium is caused by malabsorption, so not absorbing enough magnesium. It's also caused by diarrhea, alcoholism, malnutrition, excessive lactation, diabetes mellitus, and some diuretics. Hypermagnesium is caused by renal failure or increased intake of magnesium, so through taking a lot of antacids. Other kind of types of physiological or metabolic conditions like Addison's disease, acute diabetic acidosis, and dehydration, as well as hypothermia, can all cause hypermagnesemia. Okay, so remember we saw this we saw this slide earlier and we talked about principal cells versus intercalated cells. Principal cells are very important for electrolyte and fluid balance, whereas intercalated cells are more about acid-base balance. So we're going to talk about acid-base balance next. So there's several buffer systems within the body, and you might have talked about buffers if you've taken introductory chemistry classes before, which hopefully you should have since they're prerequisites. But these buffer systems might contain weak acids, in which case they're able to take up extra hydroxyl ion or OH minus and not allow a sudden shift upward in pH. They might also include weak bases, which then take up protons or H plus hydrogen ions and also don't cause a dramatic decrease in pH. So when we're thinking about buffering systems, we'll get back to those in just a moment, but in general, kind of on wide scale organismal or organ system terms in terms of buffering, we might have respiratory responses and we might have metabolic or renal system responses. So respiratory responses have to do with allowing carbon dioxide to build up or getting rid of it fairly quickly, and this happens very, very quickly, so on a scale of minutes. Whereas responses in the renal system, so excreting a lot of protons and holding on to bicarbonates, reabsorbing that, may take hours or days to occur. The specific buffering systems of the body include protein buffers in the blood, so in blood plasma and blood cells, and this is the most abundant buffer system in the body. This includes hemoglobin, so a very important blood protein, which is important for the conversion between carbon dioxide and bicarbonate. There's also phosphate buffer system and the bicarbonate carbonic acid buffer system. So when we're thinking about this idea of metabolic compensation or renal regulation, you should tie those ideas of renal and metabolic together in your heads. So this is happening in the intercalated cells of the kidney, where you're excreting protons and reabsorbing bicarbonate. So what's happening here is we have over here an antiport mechanism. So remember that symports move substances in the same direction, antiports move substances in opposite directions, so they exchange material. So here the antiport mechanism is exchanging sodium for proton, and so cells are then producing bicarbonate, which we see over here, and that bicarbonate is then moved into the capillaries that are adjacent to the nephron, so peritubular capillaries. Carbonic acid is formed, so we see that here and here. So carbonic acid is formed from carbon dioxide, which dissociates into bicarbonate and proton, and that bicarbonate passes into peritubular capillaries and returns to blood. Proton, are secreted. This is the lumen of the proximal tubule, so they stay over here. So there's lots of protons in there, and then they get both secreted into filtrate and then also excreted as acidified urine. So potassium, just a couple of other notes, potassium competes with sodium, and increased levels of potassium decrease bicarbonate reabsorption. Decreased chloride increases reabsorption of bicarbonate. Okay, so then in terms of respiratory compensation or respiratory regulation of acid-base balance, again, this occurs much more quickly, so on the order of 1 to 3 minutes. And so we might have acidosis or alkalosis. Acidosis, as the name suggests, is associated with a low pH. So in that situation, your brain is stimulated, you have increased respiration rate and also depth. So in that case, you're getting rid of more carbon dioxide. If you're hyperventilating or increasing that respiration rate, you're getting rid of carbon dioxide, and that means that it's decreasing in your blood. And you're also decreasing blood levels of carbonic acid, which increases pH and restores balance. In alkalosis, where your pH level is too high, that again stimulates your brain and decreases respiration rate, so you're getting rid of carbon dioxide more slowly. That allows it to build up, and then your carbonic acid also builds up, pH decreases, and you restore balance. So here we're thinking about the regulation of carbon dioxide in terms of respiratory compensation. So when we're talking about elevated blood levels of carbon dioxide, that's hypercapnia. When you're talking about abnormally low levels of carbon dioxide in the blood, that's hypocapnia. So again, we just saw on the last slide that the renal system is really important for hanging on to bicarbonate and getting rid of protons. Here, the change in acid-base balance with respiratory compensation happens due to the movement of carbon dioxide. So we'll get back to that in just a moment, but you should know that acidosis, which is also called acidemia, is a blood pH of less than 7.35. That then causes depression of the central nervous system. You should know that pH range. So 7.35 to 7.45 is normal. Anything lower than 7.35 is considered acidosis. Anything higher than 7.45 is considered alkalosis or alkalemia. That causes overstimulation of the central nervous system. So I mentioned that respiration and respiratory compensation is associated with carbon dioxide, whereas metabolic regulation and issues are associated with bicarbonate. So when we're thinking about the cause of different types of acidosis and alkalosis, we look at, first of all, whether it's acidosis or alkalosis, so the pH levels, and then we also look at carbon dioxide and bicarbonate levels. So if you have acidosis and you have pretty high levels of bicarbonate, so right here, this is a low pH, but a high bicarbonate level. That's respiratory acidosis. It's due to the low pH is due to having too much carbon dioxide or carbonic acid, but your bicarbonate levels are fine. Whereas metabolic acidosis down here, it's the same pH range, less than 7.35, but here you can see that your bicarbonate levels are low. So that metabolic acidosis is due to not having enough bicarbonate. For alkalosis above 7.45, we see that when we have high levels of bicarbonate, or normal levels of bicarbonate, high levels of bicarbonate, that's metabolic alkalosis. So we have this high pH range and high levels of bicarbonate. That's too much bicarbonate, metabolic alkalosis. When we have low levels of bicarbonate right here, and we have high pH, that's probably due to having not enough carbon dioxide or carbonic acid, so respiratory alkalosis. So on a quiz or an exam, if I told you that there was a case of the pH being too high and bicarbonate levels also being very high, then you should know it's metabolic alkalosis. If I said that the pH was very low and bicarbonate was also low, then it's due to metabolic acidosis. If I said that the pH was very low and there was a lot of carbon dioxide, or if I said that bicarbonate levels kind of were high to compensate, that's due to respiratory acidosis. So you should know these relationships between respiration and metabolism and acidosis and alkalosis and carbon dioxide and bicarbonate. So if we're diagnosing acid-base imbalances in a clinical setting, we first look at the pH ranges. So are they high or low compared to the normal range, which is 7.35 to 7.45. We look at whether the value of carbon dioxide, so the partial pressure of carbon dioxide or bicarbonate, could be causing the abnormality, and if it's then carbon dioxide, then it's respiratory. If it's bicarbonate, it's metabolic. And then also we saw that sometimes the bicarbonate might be elevated to kind of, or decrease to kind of compensate for those changes in carbon dioxide. So we also look at whether the non-causative value is compensating for the problem. Okay, so that's the end of the week 13 lecture, but remember this material is not going to be on the quiz that's posted today. It will be on the next quiz. So the quiz that will be open this week is just ranging from muscles through the urinary system.